Once again, welcome to Understanding Muscle-Invasive Bladder Cancer, a patient insight webinar from the Bladder Cancer Advocacy Network. BCAN is grateful for the support of our sponsors of the patient insight webinars. And our sponsors today are Genentech, EMD Serono Pfizer Partnership, Merck, Estella Seattle Genetics Partnership, Photocure, and Bristol Myers Squibb. A bladder cancer diagnosis can be terrifying to a patient and their family. What do you need to know about muscle-invasive bladder cancer, MIBC, and the treatment options for it? BCAN is delighted to have Dr. Tracey Krupski, a professor of urology at the University of Virginia today for today's program. Dr. Krupski is a surgeon whose specialty is urologic oncology, and her research focuses on health-related quality of life and outcomes of robotic versus open surgery for muscle-invasive bladder cancer. Welcome, Dr. Krupski. I'll turn it over to you.
Thank you, Megan. That was a very nice introduction. And I too would like to thank the sponsors that you can see on this slide, because it really is through their support that we are able to provide educational programs like this. So thank you very much. So today we're going to talk about muscle-invasive bladder cancer. I am Tracey Krupski. I originally am from New York, and then I went to Virginia, but I did my urologic oncology training at UCLA before I came back here. And now that I'm at UVA, I predominantly see bladder cancer patients, both the non-muscle invasive kind, which is usually how they present, and then of course, muscle invasive, as we already alluded to. So I have had funding related to bladder cancer through the American Cancer Society, and I've been part of some industry-sponsored trials for new bladder cancer therapies, which have since complete, so I have no ongoing disclosures right now. So what I thought we'd try to talk about today, and we may feel like we're jumping around, but I was going to try to take you through the way I think of presenting this to my bladder cancer patients, is first, what are the indications for a cystectomy? There can be several different reasons that somebody is going to undergo a cystectomy. And then along with that, we want to talk about who should potentially consider chemotherapy before having their big surgery. Then, since I'm the surgeon, we're going to touch a little bit on non-surgical options, but mostly we're going to spend some time talking about preparing for surgery, the expectations during surgery, what happens after surgery immediately, and then how this could influence your longer term quality of life. And then I just wanted to tie up with some exciting new things that could be coming along the pike for bladder cancer. It's been a really exciting time the last maybe 5 years or so. For 20 years, we hadn't had anything for bladder cancer, and now we're just having an explosion of information and new treatment options. So it actually is very satisfying. So let's just dive right in. Usually my experience is the BCAN population is quite sophisticated and usually asks me a lot of really poignant questions, but let's all start from the same sort of ground level and make sure that we're on the same page, so to speak. So hopefully you can see my mouse, but if not, I can just kind of walk you through it. The bladder is comprised of 3 layers. The mucosal layer, which is the surface, and I tell people that's like the mucosa of your mouth, you know, that inner lining that touches, you know, in this case, the food, but here the urine. Then there's a scaffolding layer, that's this kind of circle, or we call it the lamina propria, but it holds the bladder in an actual circle. Then the muscle that does the contracting. So the depth of invasion, not necessarily the size, is really what's most important. If it's a surface tumor like this, it means it's jutting up off of the mucosa with a little stem, and it doesn't go deep. If the root system, like a plant, is going deeper into the first layer, the lamina layer, it becomes this T1 tumor. If it was just at the surface, it's a TA tumor. And then if it's going deep into the muscle, below that surface that you can see, it's a T2 or T3, and then T4 means it's trying to grow outside the bladder into adjacent organs. Endoscopically, you can't really appreciate whether something's all the way through or not, but you can often on imaging, or if the bladder is totally removed, that's when you know if it's gone outside the bladder. So this carcinoma in situ is a little bit different. It is non-muscle invasive because it's on the surface, but by definition, it tends to act a little bit more aggressively. So we keep a very close eye on carcinoma in situ. The focus of this talk is T2, or those deep tumors going into the muscle. So just for you to visualize, endoscopically, we diagnose these by looking through a camera into the bladder. And this is a very frondular little papillary tumor. It looks like a little broccoli flowerette or a sea anemone. This is almost certainly a TA tumor, low grade, not going to be muscle invasive, and tends to keep coming back, but doesn't spread to other organs and become particularly dangerous. This, on the other hand, is kind of a representative picture of a tumor that's much more nodular. We kind of call this sessile, meaning it has a broad contact with the bladder base, and it just looks a little bit more hefty and aggressive. So for somebody who walks in the door of a urologist's office with bladder cancer, 70 to 80% are going to be this low-grade, non-muscle invasive kind. They tend to come back, but don't tend to spread. 20% of the time, you will come in the door with a bad cancer, a muscle invasive cancer. It's not that these gradually become these. Most of the time, you actually walk in the door with a bad cancer. These, unfortunately, are dangerous. They can be lethal, and so we want to treat them quite aggressively. This is one brief non-muscle invasive slide. So for that first papillary type picture, this is where you'll hear things like, what is the size of the tumor? What is the grade of the tumor? How often does it come back? Or are there more than one? When you hear those kind of words or lingo, that's non-muscle invasive cancer. And we're worried about risk stratifying them in terms of how quickly or how often they'll come back, not necessarily in terms of prognosis, like being lethal or spreading to your lungs or lymph nodes, etc. So if you hear something like low, intermediate, high risk, this is for a recurrence. Bladder therapies inside the bladder, all of that is related to non-muscle invasive disease, not muscle invasive disease. So the obvious reason that we'll see on the next slide is muscle invasive cancer. That's the most common reason to take out someone's bladder, but we can do it in the setting of these non-muscle invasive tumors for certain characteristics. So if it's T1, that means it's going down into that first layer of the bladder. High grade, grade always refers to how does it look under the microscope? Is it aggressive appearing or not aggressive appearing? And so if you have a T1 tumor going into the first layer, high grade, and it has some of those other features like it keeps coming back quickly, we can't seem to remove it entirely when we do this resections endoscopically, or it has any of these funny types of tumors that are a different cell type than the normal lining of the bladder. So the normal lining of the bladder is urothelial cancer. If you have a cancer that's called micropapillary, nested, plasmacytoid, neuroendocrine, sarcomatoid, these are aberrant or different histologies that tend to act more aggressively. So we often think of removing the bladder for these or high-grade T1 tumors that keep coming back, that could be our window for cure. So there could be an indication other than just being muscle invasive. Not the focus of this talk, but if you've done anything with bladder cancer, you know we often treat BCG. We use non-muscle invasive cancer and treat it with BCG. If you have an unresponsive tumor to BCG, you may also undergo a cystectomy. The most common reason is, as I showed in those first pictures, you have a bad cancer that's going into that muscle layer or beyond. That's maybe your first tumor ever, and that is the main indication to consider removal of the bladder. People ask, can you just remove part of the bladder? Why do you have to take the whole thing? Well, urothelial cells line everything that's in contact with urine. So the upper part of the right kidney and the tube to the right kidney, the upper part of the left kidney, the tube to the left kidney, and the entire bladder is covered with urothelial cells. So most of the time it's a field defect, and it's going to be another cancer cropping up in the lining of your bladder, even if you remove one. So there's a couple times if it's a diverticulum, which means there's only cancer in the outpouching, a very large capacity bladder, or a small tumor right at the very top. Those would be the only times your doctor may discuss with you doing just a partial cystectomy. If your tumor invades the prostate and you're a man, you have to have the whole bladder removed, because that's by definition spread into another organ. And occasionally people have opted for chemo-radiation. We're going to talk about that in a second. But if that fails, then you could consider removing the bladder at that time. So those are all the oncologic reasons to remove a bladder. There are other reasons, multiple sclerosis, things like that, spinal cord injuries. We're not talking about those. We're just talking about cancer reasons. There's lots of different guidelines that you can look up to follow on the internet. There's non-muscle invasive, muscle invasive, non-metastatic. There's European guidelines. There's the AUA, which is our national organization. And I'm sure you're familiar with the National Comprehensive Cancer Network. They also put out these algorithms and flow sheets to help figure out how we should best treat cancer. So if you have muscle invasive bladder cancer, there is a choice of the two main pathways to be treated. There is surgical removal of the bladder, or there is chemo-radiation. So this first one is cystectomy, removing the bladder. If you're a man, you remove the prostate along with it. If you're a woman, often part of the uterus, cervix, or some portion of the vagina may be removed as well. You have to reroute the kidneys. You have to use intestine for a reservoir, and we traditionally remove lymph nodes, which are near the large vessels to your legs that give you blood flow. So it's a major operation dealing with a lot of different organs. If you choose to not do that, you may be older, maybe medically you don't think you're going to do well with that big a surgery. You may opt for what we call chemo-radiation or trimodal therapy. That means you do an endoscopic surgery to remove all the visible tumor and go as deep as we could to try to get rid of everything that we can see on the inside of the bladder. Then you get radiation and chemotherapy at the same time. And that may go on for like 5 weeks while we are treating the bladder cancer and treating your entire bladder with a combination of radiation and chemotherapy. That is kind of represented. I just wanted to show you these national comprehensive guidelines. So if you look, you have stage 2. If you can remember back to that original diagram, that means it's the deep going into the muscle invasive bladder cancer. And if you're a cystectomy candidate, you would proceed along this side of the pathway. If you don't want to have a cystectomy, or you're not medically maybe strong enough for it, we're going to this star part of things. So this little segue here is talking about not doing surgery for muscle invasive bladder cancer, but rather considering chemo-radiation. So a few words about chemo-radiation. Again, this is what I was alluding to. It's very important to go under anesthesia, have the urologist scope you, look in through your urethra, and remove as much visible tumor as they can. That means going almost all the way through the muscle to the point where they get to the fat around your bladder. And then you keep a catheter for a little while you heal that little hole. And then you can consider getting the radiation to both the bladder as well as some of those lymph nodes that we remove during a surgical part. So the pelvic lymph nodes and the bladder get radiated, and we're able to then treat you with chemotherapy, which is sensitizing. What that means is it's making the radiation work better. So we use that in conjunction. They're synergistic, so to speak. Occasionally you'll get some markers put in the bladder to sort of help focus where the radiation needs to go. And there's a 5 to 7% chance that after just a really, really aggressive resection in the operating room, you may be able to be rendered tumor-free. That's what T0 means. no more cancer in your bladder if you have a really aggressive resection. Now that's not standard, but that's part of why we call it do all three: a good resection, chemotherapy, and radiation. So if you're thinking about this option, it's going to save your bladder, right? You don't have to worry about removing the bladder and what are you going to do for a reservoir. This is a third of the patients are done. They've kept their bladder, their cancer doesn't come back, and they don't have to worry about it. A third go on to have their cancer come back, but it's still within their bladder, so they can go back to that cystectomy option again. And then a third of them, the disease will progress to other organs and there would be no role for removing the bladder anymore. So in a sense, you can think of it as like 2/3 respond initially and do well, and maybe up to 30 to 40% continue to do well and never need anything else after chemoradiation. So this is a reasonable option. You should not just get radiation alone. Radiation alone is not as curative as chemoradiation. And if you do chemoradiation and you're closely followed and you go on to have a recurrence in your bladder, the bladder cancer comes back, then we remove your bladder. That's what salvage cystectomy means, meaning we didn't do it up front. We're going to do it after you had this other therapy. You still do as well. Now that's not quite as high of level evidence, but it can be done and you can be cured by removing the bladder if chemoradiation did not work. So here's just one little graph. We call these survival curves. So these are overall survival curves. These are people who got radiation only, and these are the people who got chemotherapy and radiation. And when these curves are separated like this, there's a much better chance of being cured with the chemotherapy combined with radiation. Again, just to emphasize, close follow-up. Somebody needs to look in your bladder every 3 months to see if that cancer is coming back. CTs or PET scans are not good for this because urine tends to pick up the PET tracers, so you can't tell anything that's going on in the bladder. We don't want your kidneys to get blocked. That's what hydronephrosis means. And the ideal patient is one who had a solitary muscle invasive tumor in one spot that's been fully resected. If it's sort of dotting all over the bladder or encompassing the whole half wall of the bladder, those are not going to respond as well as a small tumor, fully resected, one spot, not blocking any kidneys, that type of thing.